see in your book. Let me look and see if I've got comments on these. I actually printed them out larger scale for my old eyes. Again, it takes you through routes, mechanisms, and I think we've pretty much covered all these. But again, special considerations are going to be more the monitoring side effect. I mentioned kind of the weirdness with like nitroprusside with the cyanide thing. I only saw probably 2 patients when we were using it. Often I only saw a couple of patients where that ever happened, mainly because people were aware of it. But the reason I also mention that is, remember, we're only one drug shortage away, or one hurricane away from having to use other agents. I try to remind some of the medical residents and students I work with, and they're like, they don't use that anymore. I'm like, well, who knew that a pharmaceutical plant in North Carolina was going to get deep sixed, right? So we better have options, okay? All right. Switching gears, again, any questions on that? That's more of the cardiovascular. We will talk about antidysrhythmics here in a little while too. That's kind of the cardiovascular part. Any questions on those? Vasopressors, inotropes, vasodilators, and hypertensives. Okay. And by the way, I should have said this up front. I am not really going into dosing stuff. Number one, for time. Number two, because that's the kind of stuff you can look up. Okay. Because if I don't know the dose, I got to look it up anyway, right? Okay, going into more neuro stuff, and you might notice this is a pretty big blanket here, right? Sedatives, anesthetics, analgesics, antipsychotics, anticonvulsants. It's like, wow, that's a big conglomeration, okay? So all of these, although you can argue antipsychotics do work on the nervous system too, but they're mechanistically, they do focus on different pathways. Really, most of these are to depress the central nervous system activity in some form or fashion. If you think about it, that's kind of what opiates are doing too. It's decreasing your pain response, right? So some of the ones we talk about will lead in here. Now, one thing to remember, some of these meds may be members of multiple classes, and it's probably more appropriate to say some of the drugs may be used for more than one purpose, okay? For instance, we've talked about diazepam and lorazepam for like seizures, but we may also use them for alcohol withdrawal. We may use them as a sedative in the ICU to facilitate mechanical ventilation, okay? And you'll probably see a combination of that when you do your neurocritical care clinicals as well, okay? So do understand there may be some interplay, if you will, of some of the indications here. All right? Side effects may vary on some nuances, but most of the ones we have to worry about are respiratory depression. If we suppress the central nervous, and that's pretty redundant, right? This is one of the statements I told you all at the beginning. You're going to be going, yeah, it kind of makes sense. Why are we even going over this? Well, just a reminder. The other thing is, too, we talked about summative effect. This is one where 1 + 1 may equal 10. If I've got 2 different sedatives on board, I may have a predictable response with both, but I'll put them together and I get a more pronounced response, okay? Waveform capnography, I will tell you, this is one where pre-hospital is probably far ahead of the hospital on use. In that if I've got somebody on sedatives and pain meds and whatnot, the standard of care has quickly become waveform capnography. And most, if not all, EMS pre-hospital uses it. And again, in my opinion, better than we do in the hospital, just to be honest with you. They do it obviously in the OR and the ICUs, but on the floors where we got people on PCAs and stuff like that, we may have them on an O2 sat monitor, and by the time that alarm's at us, the cow may be out of the barn, okay? These branch out into 2 broad terms, but they're used kind of interchangeably. Sedatives and anesthetics, okay? When you get into classes, again, you're going to see a lot of them. You're like, oh yeah, that's all in the same class. That's right, okay? So midazolam, Versed, diazepam, Valium, lorazepam, Ativan, they're all benzodiazepines. They have a little bit different characteristics, but they're all in the same class. Phenobarbital, we're increasingly using that. It's an older drug. We obviously use it for seizures, but we're also increasingly using it to prevent alcohol withdrawal. So we kind of dusted that one off the shelf, and we're using it a lot more in the ICU for that. Dexmedetomidine or Precedex is one that you will see used in the units. It actually hits the alpha-2 receptor, which is also the same receptor like clonidine uses. It's probably more of a sedative than it is an anesthetic, but you can use it for pain control, okay? But it's usually more of a sedative that you'll see in the unit, okay? I always ask people, and I'm old, everybody ever see Young Frankenstein? Everybody ever see him? Old enough, if you haven't seen it, watch it sometimes. Terry Darr, who was in it, passed away this week. But it's a Mel Brooks movie. There's a scene in it where he's talking about give a sedative. They're playing charades and it's sedative. Anyway, I'm sorry, I'm altered. So then you get into anesthetics, propofol. That one, and I think they kind of talk about this in your text. It basically, it hits GABA. So when I think of GABA, I think like gabapentin, okay? So it hits GABA, also kind of blocks NMDA. Etomidate or amidate's really just a general anesthetic. We don't truthfully know exactly how it works. And then ketamine is an NMDA blocker, more of a dissociative anesthetic, and it is a PCP derivative. Now, real quick, in 2023, American College of Emergency Physicians issued a statement that they no longer endorse. They actually have a paper that went back as far as 2009. It was a white paper. The term excited delirium is no longer a recognized medical term by the American College of Emergency Physicians. Why is that? Have there been any lawsuits in the United States in the last 5 years related to ketamine use and excited delirium in the United States?
Colorado.
Oh, yeah. Colorado, North Charleston. Those are just the two I'm aware of, but there's been a bunch of them. So who is typically, and by the way, I'm not throwing shade here, okay? All joking aside. Who's typically on scene before you get on scene?
Police.
And what do they want done? All right, so, and by the way, this is the term that they're replacing with, American College of Emergency Physicians is calling it hyperactive delirium with severe agitation. The key word is agitation, okay? The key word is agitation. Do we have other classes of drugs other than ketamine that can decrease agitation? Absolutely, okay? So, the point being is, we do need to have that conversation. Is this a law enforcement issue? Is this a psychiatric emergency? Or is this somebody that, for whatever reason, because of acute delirium, is a danger to themselves or others where I might need to sedate them? But the thing there is, ketamine may not be our sole drug. Now, is ketamine useful? Absolutely, okay, absolutely. This was another one of the drugs that at different doses, we all know it does different things. The criticism when it started getting used in the Greater Knoxville area by a lot of the ED physicians was that per protocol, and this was another one I had a conversation with the local medical director, an electronic communication, but it was communication, where I'm like, you need to be doing per kilo doses, not one size fits all. And the criticism that some of the ED docs would have is like, they come in and they're like, what the heck? You know, we're tubing this patient. Why are we having to tube this patient? Well, we did per protocol, we did ketamine. Well, again, it's what size does one size fit all? So I just want to mention that because that is important on that. Okay, antipsychotics, real quick. Haloperidol, and you might be going, why are we talking about antipsychotics with critical care? Okay, well, olanzapine, which is Zyprexa, and quetiapine, which is Seroquel, we absolutely see a phenomena in the ICU called ICU psychosis. There's no day or night, there's constant noise, there's no good sleep patterns. They're like thinking, oh my God, I'm really sick because I'm in here, right? And so it's your orientation for when you wake up every morning is totally out of whack. Well, that gets even more pronounced. We're talking about elderly use of agents, right? In an older person, it's even more pronounced. So haloperidol might be a better agent to use for agitation in the situation. We also use it for intractable nausea, vomiting, okay, things like that. So do understand that's where some of the antipsychotics will be used. Analgesics is kind of bread and butter. Probably one of the best things in the last 30 years in EMS was pre-hospital analgesia, okay? Fentanyl, sufentanil, which is mainly a hospital, we don't even carry it in our hospital, morphine, hydromorphone. All of them are opiates. All of them are narcotics. There are nuances with half-life and whatnot, but don't confuse potency with efficacy, okay? If one of them is more potent, that just means we give less of it. That's all that means, okay? Does not mean you can't use, morphine is not better, or Dilaudid is not better than morphine. Morphine is not better than Dilaudid. Patients will argue with you. If we use the right dose, then, we do need to consider allergies and stuff like that. Now, Bufen is kind of an interesting one. It's a partial agonist-antagonist, kind of like with buprenorphine we talked like. Where it gets used a lot of times is itching. Like if a patient's had an epidural, or if they have an epidural and they're itching, they'll actually give them Bufen and it helps that itching. That's kind of where you'll see that used. And we don't see it used a lot. Good old acetaminophen, this is misspelled, I didn't do that. Acetaminophen, for pain, it doesn't really help inflammation, but it's still very potent. You'll hear more and more and more focus on what's called multimodal pain control. We use drugs from multiple classes to try to help control pain, to mitigate use of addictive agents, or to decrease toxicity risk, okay? And then ketorolac, Toradol, non-steroidals, as long as if there's no contraindications, they don't have a rip-roaring GI bleed, or they're not allergic to it. Renal failure, you gotta be a little careful. I'm a huge ketorolac fan, okay? If you're using it more than 4 or 5 days, you can get into GI bleeding risk more, unless somebody's like on Eliquis or Coumadin, you gotta be careful. But it's probably been 20 years ago now, a little over 22 years ago, I had a surgery done, and afterward, the surgeon said, I'm gonna give you some Toradol. And I thought, oh Lord, I'm gonna ride in pain. I'm gonna sit here all night and just be in pain. I loved it. I wasn't loopy. It's equal potent to morphine, worked great. 2 years after that, I had a pretty major surgery done. I had to be in the ICU overnight. And it was at UT, so I knew the nurses and whatnot. And one of them, this is before we had computerized medical records, and one of the nurses said, hey, what do you want? And are you uncomfortable? And I said, yeah, I'm in some pain. She goes, what do you want? I said, can I get some Toradol? And she goes, look, it was like a menu at Aubrey's. You've got all this stuff. And I was like, I'd just like some Toradol. And it does work. It does work. Again, do think through contraindications, but it is a very effective agent that you can use. Backing up real quick on the analgesics, do also think about not just potency and efficacy, but really, side effects, half-life, blood pressure effects. Because if you do give sedation, you can get a lowering in your blood pressure, and you do need to think about that. Okay, anticonvulsants, and then after this, let me look real quick, guys. After this section, we'll take another quick break. So anticonvulsants, we're still in the neuro realm here, okay? The way I conceptualize anticonvulsants is kind of like I do antibiotics. Now you might go, okay, this guy totally lost it, right? When we think about antibiotics, we think of broad spectrum or narrow spectrum. Does it just treat like one specific type of bacteria like gram-positive, gram-negatives, or does it treat a lot? I call it Bambi-cillin or Godzilla-cillin, okay? What does it treat? Same thing with anticonvulsants, okay? So when we look at stuff like levetiracetam or Keppra, phenytoin, of course, dilantin, fosphenytoin, basically still essentially for all intents and purposes, dilantin, valproic acid, or pentobarbital. Pentobarb's right, it's more than one that everybody can get it. That's really more when you have totally uncontrollable seizures. You're trying to shut the nervous system down, but it's phenobarb would be also in this realm, okay? You could also add in this list lacosamide or Vimpat. And I'm focusing, by the way, when I list these, are basically agents that are going to be available to me IV, particularly if I'm treating status. Also, you'll see them used a lot when you do your clinicals. Not only do we use them when we're treating seizures, we're going to use them prophylactically like in traumatic brain injury, okay? So we may very well put somebody on Keppra for a couple of weeks after a brain insult, okay? And so it's not always that they're gonna stay on it for that. Levetiracetam, or Keppra, you're seeing tons of it used increasingly. Very effective, very titratable. The one downside, particularly long-term, is some people will get like behavioral health and personality kind of changes. It's not everybody. That's probably the most frequent reason I see them have to be switched to something else, is for that. The other thing is, you'll see some of these agents, particularly valproic acid, you'll see it used for behavioral health reasons. I'm sorry?
Some of the seizure medicines that you're
Yes.
Some of them, there are some tests that you can do to find out, make sure the levels are correct, right?
Their levels?
The levels
Yes,
are correct.
absolutely.
But they're telling me that Kepra's one that they don't really do a lot of, because
Yep.
it's the one that I think is the costly test.
So very good question. So stuff like valproic acid, for seizures, we definitely check levels. For behavioral health, not so much, like bipolar. I see as many people on valproic acid for bipolar as I do for seizures. So phenytoin, fosphenytoin, we absolutely check levels, because not only does it tell us if they're therapeutic, of course, how do I know if they're therapeutic? They're not seizing. And our goal, by the way, our goal with seizures is decrease number of seizures or quit seizures with the least number of drugs with the least number of side effects. That's my goal. So, back to levetiracetam. So I should be measuring levels with phenytoin, fosphenytoin, valproic acid, and even if they're on phenobarb, I'd be measuring levels. Levetiracetam, because its effectiveness, it has like what we call a wide therapeutic window. Most patients, we just titrate in terms of 250 or 500 milligram doses, and we don't have to check levels. About the only time I see levels checked are to confirm absorption or compliance, like patients coming in, they're frequent flyers, like, did they really take this? Okay, or maybe to see if there's some toxicity involved. But usually the level doesn't come back for 2, 3, 4 days. So to me, it's not very helpful. Like a phenytoin level or a valproic acid level, I'll get that back within hours. A levetiracetam level, I don't get back. And there's not, and this is an opinion, there's not a lot of utility in ordering a levetiracetam level. I see some of the neurologists do it, and I'm like, but are you really doing anything with that? You know, and it has to be a trough. I had this discussion with a neuro NP about 2 weeks ago, because they ordered a Keppra level and said, oh, they're toxic. And I was like, but they got the level 2 hours after the last dose. I'm like, that's not a trough. I'm like, so how do you really tell they're toxic? So anyway, and I try to be I try to be respectful, but that, yeah, to your point, it doesn't make a lot of sense, okay? All right, real quick, and then we're gonna take a break. This is just kind of the summary statement on the benzodiazepines. Notice the multiple routes, including with midazolam of IN, okay? When we're talking about absorption and onset, if I didn't have IV access and I gave, and this is, by the way, also onset's important to remember, so I don't do what's called dose stacking. I think one of you guys was talking about that with Valium on somebody, okay? If I give my drug time to work, okay? So if I got a pediatric patient, and you know, if you're, and all of us have been there, you're going, oh gosh, you know, sphincter factor is tight because you're watching that poor child seize. But if I've had to do intranasal, I'm not expecting it to work in 1 or 2 minutes. It may be more like 5 minutes, right? And so, but if I sit there and go dose, 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 once it all takes effect, then I may detube in that patient, right? Because now I've put them out, right? So, but anyway, so that's on the benzos. That next one really has the phenobarb, the dexmedetomidine, which is the Precedex. Look through my notes here. We talked through mechanisms. We talked through that they may be used. I'm just looking at my notes here. These are really more to facilitate ventilation a lot of times, or sedation. Etomidate, we'll make one quick statement here. So etomidate, we actually use a lot of etomidate for intubation at the hospital. And not an unusual combo from our anesthesia residents is rocuronium and etomidate, okay? Etomidate, it's usually a per kilo kind of dose, so is rock. But about a third of the patients, particularly if you give higher doses with etomidate, they'll get a myoclonus, but it's not a seizure, okay? It'll kind of freak you out. Has anybody ever seen that with etomidate? So it kind of freaks you out. It's kind of dose related. Sometimes it's mitigated by giving a benzodiazepine, okay? But it's not a seizure, okay? And it's a fairly short-acting drug, which is also important to remember, because once my etomidate wears off, my rocuronium hasn't worn off, which means they need sedation, right? And then, and again, I'm sorry I'm having to like look up here. These are like the olanzapine, quetiapine. Main thing there, you'll see it used more for ICU sedation or agitation or delirium. Do be careful, particularly with quetiapine. If somebody already has a prolonged QT, this one can prolong it more. Same thing with Haldol, by the way, but typically more with high doses of Haldol. Okay, so do remember that. And fentanyl, sufentanil.
Kids were having psychotic episodes. It sounds something like that.
Okay, we've covered all of the, I'm just trying to make sure my notes are. Let's go ahead and take a quick break for about 10 minutes. Questions on that section? And that's a big smorgasbord of stuff there.
I've got one kind of off the top.
Yeah, go for it.
What's the name of that? They was given it to pediatrics for like an antidepressant, and they was having a lot of psychotic episodes. It kind of sounds like Haldol, but I'm not for sure. Because I've only seen it 3 times and this is
Sure.
over 5 years. Well, over 18 years.
Right,
I've only seen it
right.
3 times. And we ended up dosing them with ketamine to calm them down.
I'm trying to think, and you said it's for pediatric depression?
Well, when I mean pediatric, between the ages, all these kids were between the ages of 10 or 11 to 15, and they was on some type of,
Was it an ADHD medicine?
it could have been an ADHD or depression medicine, something, but they were, and they were
Prozac.
having an episode where they were really excited.
Huh. I'm blanking at the moment.
Like a serotonin syndrome?
I don't know what, I
That
mean,
could, that could
That's-
definitely.
that's what I-
Sounds almost like,
And that's what I've seen.
Like what?
so we had to calm them down with ketamine because they were, 2 were real aggressive, and I really don't remember what the other one was, but they was just, I mean, you know, they was just kids. But it was
I can't
something
think-